Good afternoon, everyone. My name is Adil El Maftouhi. I'm from Switzerland, Geneva, and Paris. And today I'm going to talk about the multimodality approach with the Solix platform. Solix platform is a spectral domain with a high sensitivity camera with a high rate of 120,000 scans per second, with a very good axial resolution of 5 micron. The full range retina scan with 16 millimeters and 6 millimeters depth. The classic OCT angiography with a cube of 3 by 3 until 12 by 12, and the possibility to create a composite of 16 by 16, and the fundus camera of 45 degrees. So you can make some beautiful picture about the optic nerve, posterior pole, also anterior segment associated with your classic V-scan. The last evolution of the OCT using the full range technology embedded on the Solix platform and allowing the possibility to increase the depth using the mirror image until 6 millimeters depth. And therefore, with this large scan, you can highlight the scan of myopic patient, highlight the visualization of the vitreous component with a beautiful visualization of the premacular bursa and Martigani area as compared to the conventional OCT with a small depth of 3 millimeters. And look here, the connection between the Martigani area and the premacular bursa. Another case here with a coloboma with a very large premacular bursa. You can highlight the area of Martigani. And look, you can have another modality with the OCT on face. You can image the two pockets of premacular bursa and Martigani area as compared to the scan. With the age, there is a connection with the premacular bursa and Martigani area. It's always difficult to analyze a dynamic tissue with a static approach. That's why I'm trying to give some dynamic approach with several consecutive scans. Look here, you can see the connection between premacular bursa and Martigani area. And with the PVD, you can also identify the connection with the posterior vitreal cortex and premacular bursa in case of vitreous liquefaction and PVD. And look here, another case of dynamic approach. You can distinguish the difference about liquefaction of the vitreous, the connection between the posterior vitreal cortex and the premacular bursa. You can also see the movie of the prevascular fiber in case of PVD. Another case of foveal traction with a full range retina. Also, this connection between the premacular bursa and the posterior cortex vitreous. And you can see also the reaction of the photoreceptor. With this very large scan, you can have some image about the interface in arcade area where you observe the first beginning PVD here with this schisis of posterior yelloid in PVD. In a myopic patient with a very high depth, it's really easy to scan the patient as compared to the conventional OCT when you have a disturbance about the neural image in this case. Look here, a dome-shaped macula. You can have the whole image in the window, acquisition window. You can also scan the peripheral area, and look here, we observe the beginning of retinal schisis, and you can move the fixation and scan the bullous retinal peripheral schisis in this patient with a fluorescent retina. You can also image some lesion like peripheral retinal tears, and look here, you can see the hole and this retinal detachment. Another kind of lesion in case of inflammation in toxoplasma retinitis, we observe also some punctuation within the vitreous due to the inflammation, in this case of toxoplasma. You can make a very quick screening of the retina with the retinal cube, and you can have also the ganglion cell layer, the retinal thickness, and you can cover the whole retina with a scan of 12 millimeters in just 5 seconds. And you have also a database for GCC. You can also associate vascular density. OCT angiography can perform very quickly with very high definition, and the main problem in OCTA is to have a good compromise between high definition and time acquisition. And look here, with the Solix, you have a very dense B-scan within the cube, and you keep the information even with a large scan of 12 millimeters due to the scan density. And the scan density is the space between each B-scan, varying to 12 micron until 20 micron, and look at time acquisition 4 seconds until 50 seconds. And the specificity of OCTA for Octoview is algorithm, SADA algorithm, providing a very good contrast between the correlation signal and the background. And you can highlight the identification of the vascular plexus, capillaries within the RNFL, superficial plexus, intermediate deep plexus capillaries, and deep plexus capillaries with a very high definition according to the histology. And look here, with a cube of 12 by 12, you can easily identify CNV, in this case of a chronic CNC. You keep the information even with a very large scan. The projection artifact removal is really improved as compared to the XR with the Solix version to put off the projection artifact from the superficial plexus, inducing the artifact in the deep plexus, in the choriocapillaries, and the Brooks membrane. And it's mandatory to have projection artifact removal to analyze the vascular density in the deep plexus. Look in this case of diabetic retinopathy. When you don't have power, and when you have power, you have a very good representation of your vascular density with this removal projection. And look, also in the coil capillaries, you put off this artifact projection in order to better identify the presence of the CNV, of the decorrelation signal within the outer nuclear layer segmentation. And here we can compare with the OCT angiography overlay on the B-scan. And so we can isolate the decorrelation signal and to improve the follow-up of CNV. And look here, the CNV follow-up, and you can see very well the maturation of the vessel and the effect of anti-VEGF in the recent part of the CNV. With PAR, you can improve the sensitivity to CNV screening. In this case of incipient CNV, look with PAR, you can isolate the decorrelation syndrome. Also, on the OCTA overlay on the B-scan, you can follow this patient 2 years after with the ingrowth of the CNV, but no exudation associated until 3 years after. And look here, the difference with the B-scan. Here we observe a slight PED, but with no exudation. The segmentation in the Solix platform is really also improved, and you can correct the segmentation with a tool propagation. You can correct just one line, and you propagate the correction over the whole cube. And look here in this case of vascular speed. And after, we can better isolate the CNV decorrelation signal. The segmentation is really improved, and in the past, it was very difficult to identify CNV and PED due to the problem of the segmentation of the Brooks membrane and the segmentation of the RPE. And now, we really improve the segmentation of RPE and Brooks membrane thanks to the deep learning. And look here, automatic segmentation with no manipulation. You can highlight the presence of the CNV in OCT angiography, in this case of vascular PED. In another case, with no PAR, are associated with improved segmentation, and look the good visualization of the CNV. We can compare two generations of OCT. Look, in this case of vascular PED with XR advantage, and compare to the Solix. And look the difference of the segmentation. Now we can identify the CNV within the PED. Before, it was difficult due to the problem of the segmentation. So, improvement of the segmentation, improvement of the PAR software give a better visualization of neovascular flow associated with PED. Okay, this another very new pattern is a 3D volume rendering available just for the cube of 3 by 3 millimeters. And look, in this case of best disease complicated with the CNV, you can obtain the real shape of the CNV in 3 dimensions. Look here, the dome-shaped appearance of this CNV. Another case of CNV complicated McTail, and look here, in 3 dimensions, you can see the bad connection between the superficial plexus dilated with intraretinal CNV. And look here, this connection with capillary dilation directly in the CNV with the three dimensions. And you can follow also this patient here with two-dimension CT angiography, and in three-dimension we observe a very good vasoconstriction of the CNV after anti-VEGF therapy. Another case of CNV in case of a myopic patient. And look here, a very beautiful case of CNV type 4 to show the precise definition of OCTA embedded on Solix. And look here, we're going to move the slab through the retina, and you can highlight the abnormal connection between superficial vascular capillaries and the CNV. And look here, the decoration of the CNV, and you can see here the connection between two capillaries in the CNV. And you can zoom with no lose the definition. You have the possibility to have quantification for the CNV follow-up with flow surface, and the analysis of flow surface give the changes and the recurrence of the CNV when you observe an increase of flow surface, as is in case you observe flow surface increase due to the recurrence of the CNV, and you can make a very precise monitoring in weight and another case with flow surface, and here in incipient CNV, you observe changes of flow surface due to thickening of anastomosis arcade before the first sign of exudation. And look, with this nice resolution and nice signal, you can follow the patient during 2 years, and this patient keep the same visual acuity of 20/20, but we observe that the flow surface is not correlated with the visual acuity. And you observe maturation of the vessels. OCTA is very useful for the early detection with a very nice definition, like in this case of Drizen without fluid. And look in OCT angiography, you observe a very nice decorrelation signal corresponding to the CNV after the first sign of exudation. That's why now we can have a Drizen screening with OCTA, with BACE scan, OCT angiography, and en-face OCT to check if there is incipient CNV. You can also check in case of pseudo-vitelliform deposit. Here there is no signal. Another case, we observe the fragmentation of the pseudo-vitelliform deposit a few months later. But in BACE scan, you have some Drizen, a little area of atrophy, thickening of Brooks membrane, but no fluid. But in the OCTA, we observe the presence of incipient CNV. And look here, after the first sign of exudation, we begin the treatment, and this is the follow-up of 3 years after anti-VEGF therapy. And you can obtain this movie due to the quality of the signal And the flow surface demonstrates that we contain the surface of the lesion. Look here, the flow surface is 0.5, and after treatment is 0.48. The CNV is not always in weight IMD, and sometimes you have CNV in chronic CSC or in a pachychoroid spectrum, and you have to use ENFAS to have a choroidal topography. This is an ENFAS OCT obtained by the OCT angiography cube of 12 by 12, and you can analyze the topography of the vessel. And look here, a pachychoroid spectrum in the left eye. And sometimes you can make a very good correlation between a small deposit in a pachychoroid pigment epitheliopathy and the area of choroidal dilation. Look, at the same area of the small lesion. And look here, you can observe the thinning of the choriocapillaris due to choroidal dilation, explaining the mechanism of pachychoroid. So, with one cube, you can have OCT angiography, the whole retinal thickness, and look here, we observe the thinning of the retina in the right eye. And look here, the dilation of the choroidal vessel in the same part, and we can make a comparison with ENFAS OCT. And in the same area, we observe a pigment epithelium disturbance in the same area. And look here, with the thinning of the retina on this scan. And sometimes you can have pachychoroid associated with the CNV, and it's a game changer to make a good diagnosis, to give a good treatment, like a B therapy of anti-VEGF plus PDT. And look here, you can see a beautiful signal of the correlation. But here, the retinal cube, we observe a dilation of the choroid corresponding to the pachychoroid spectrum, and the diagnosis was CNV in pachychoroid spectrum. OCTA in diabetic retinopathy, you can identify the capillary dropout, especially in the superficial plexus, the microaneurysm in the deep plexus, and we would like to follow the area of this capillary dropout in OCT angiography, and to check the presence or not of pre-retinal CNV, like in this case, on OCT angiography, or in fluorescein angiography, the leakage was masked by the subretinal hemorrhage due to the motion of the hemorrhage. And look here, the CNV on the optic nerve, and you can make some composite to check the peripheral area. On the left side, you can observe the fluorescein angiography with the optos. And look here, you can identify the presence of the preretinal CNV. And you can have the same visualization, but with a 3D rendering, and to isolate the presence of the CNV. Look, you can use the analytics tools to quantify the flow, surface phase, the vascular density in the peripheral area, to follow the evolution of the avascular zone during the treatment. And look here, this is the 5 years follow-up of diabetic retinopathy. And the visual acuity still remain the same because the vascular density of the deep plexus continue to be pretty good, and we already know that the vascular density of the deep plexus is directly correlated with the visual acuity. And it's mandatory to have a trend analysis because when you perform OCT angiography, sometimes you have some variation of the signal due to the acquisition or disturbance of the opacities media, and this statistic trend is necessary to validate changes in vascular density due to the signal variation. And you can quantify the area of capillaries dropout and quantify the vascular density for superficial plexus and the deep plexus, and you can also check the peripheral area of capillary dropouts, like in this case of BRV. You can use also OCT angiography for inflammatory disease like acute multifocal placoid pigment encephalopathy. You can observe microvascular dropout within the choroid capillaries in OCTA as compared to the ICG, and to follow up this patient and look here after 1 month without treatment, you observe the resolution of this microvascular dropout. And look, with one cube, you have several multi-modalities. OCT A of 9x9, the deep plexus, outer nuclear layer, okay, no signal. Choriocapillaries, very small disturbance due to the atrophy. And look here with the en-face OCT, you confirm the presence of reticular dystrophy. And the en-face OCT, we can see the area of atrophy with the same cube, and also the whole retinal thickness, and you can make your diagnosis with just one cube in few seconds. Another case here of the Combs dystrophy. You observe the thinning of the foveal avascular zone, and look here with the en-face OCT. We observe the characteristic changes within the retina, especially in the outer nuclear layer. There is some change in reflectivity with alteration of LPD complex. And look here, the B-scan corresponding. So you can use more information on the OCT, B-scan, en-face OCT, OCT angiography to give your diagnosis. Here the screening of nevus. You can check your nevus with OCT angiography, fundus camera, if there is a presence of free or not free, if there is a thickening of the lesion. In this case, the lesion is pretty plain, and you can make a measure of the surface directly on the base scan. Hémangioma with a very full range retinal, it's really easy with a large scan to make some scan of this lesion. Look here, in this case with a full range retinal. Solix Octoview is the first OCT who present a unique report combined structural OCT with the RNFL, GCC, and the functional OCT with OCT angiography. We know with OCT angiography, you can quantify the radial peripapillary capillaries within the RNFL, superficial plexus within the ganglion cell layer, and deep complex within the inner nuclear layer. And we know that the nucleus of Müller cell is in the INR. You can use en-face OCT to analyze the location of the defect. And look here, you can make a very good comparison with the GCC. And look here, the first beginning defect in the superior temporal location, as compared with the normal shape of the RNA. We know there is a good correlation between structural OCT and OCT-A, but currently we don't know what is the egg or the chicken. If there is on the beginning a functional defect before the structural damage. It still remains this question. But currently, we know there is a floor effect in the structural OCT, especially in advanced glaucoma. We know also that this floor effect is in OCT-A is less than as compared to the structural OCT. And probably we can use the OCT-A in advanced glaucoma associated with the whole retinal thickness in this kind of patient. And look here, this is a publication of Gabor Olo in a very advanced stage of glaucoma. And he compared the evolution with OCT angiography associated with the visual field evolution in this kind of patient. And it's the first time we have in one report the structural OCT and functional OCT. Here we observe GCC sealing with the beginning of sealing of RNFL compared with OCT angiography. Another case of the line optic neuritis, you can see on en-face OCT the defect of RNFL on both eyes. And you can have a trend analysis of the RNFL and also with OCT angiography. Here in optic neuropathy, in a tobacco alcohol, you observe the sealing around the GCC sealing around the foveal vascular zone, and you can make a correlation with visual field as the presence of a central scrotum. So, with retinal OCT, you can use BScan, en-face OCT, OCT angiography to make your diagnosis even in optic nerve analysis. So we can use the full range technology for the anterior segment, and the depth increase, allowing the visualization of the whole anterior segment to make a very easy biometry with angle to angle, anterior chamber depth, crystalline lens rise, and white to white with a very wide scan of 18 millimeters with 6 millimeters depth. Now you can also have automatic biometry, and you can make a measure of white to white directly in infrared camera with a specific ring caliper. And look here, now is upcoming software with an automatic biometry, and you can use this information to help the choice of diameter ICL using the regression formula as the Nakamura formula, and you can predict also the bolting before the surgery. You can check the safe distance and the bolting in different conditions, photopic condition and scotopic condition, and to analyze the safe distance in artisan vertical AOM, and the bolting in this case in hyperopic AOM. You can have the whole image of the crystalline lens, anterior crystalline up to the posterior capsule, to analyze the organization of the opacity. And here you can see conjunctival cataracts, contraction of the posterior capsule, and we know sometimes we can have some complication in this case. You can analyze IOL, the presence of PCO, or sometimes whitening and glistening. You can identify also the anterior yelloid and the visualization of anterior vitreous body. You can quantify the involvement of the crystalline lens rise in case of angle closer glaucoma. You can identify the scleral spurs, also the Schlenz scanner. You can analyze the angle, in this case of conus initial, concave iris in pigmentary dispersion, open angle and angle closer. You can check the iridotomy if it is non-transfixing or transfixing. And you can use also the 3D approach with the on-face OCT to check the iridotomy. And look here, in 5 seconds, you can obtain this cube, and you can check the iridotomy to avoid the eye motion of the patient. Because when you use just one B-scan, you are disturbed by the eye motion of the patient. If you can use the cube approach, it's really easy to check your iridotomy. You can analyze some conjunctival lesion, in this case of news. You can measure the news. And you can have a very high resolution of the cornea with a 5 micron. It's easily to identify the epithelium and the basal membrane of the epithelium in order to generate epithelium mapping. And now we have an epithelium mapping of 10 millimeters. In the beginning of the epithelium mapping, we had a 6 millimeters area of the mapping, but it wasn't enough to identify slight epithelium changes, especially in the area of 7 to 9 millimeters. And look here, the 9 millimeters, 10 millimeters, and you observe very slight changes in this area. And when you have a normalized epithelium mapping, you change the scale to 5 micron to 2 micron to highlight the slight changes. And with epithelium mapping of the past, I propose a classification of the dry eye. In a normal eye, you have a uniform epithelium mapping. In the first stage, we observe an hyperplasia, suggesting an auto-regulation mechanism between the epithelium and the tears. In the moderate stage of the dry eye, the lack of tear induces an increase of blinking frequency, inducing more friction between the eyelid and the epithelium, inducing a sealing of the upper part of the epithelium. And the last stage, we observe the whole retinal seeding due to excessive pressure and probably also by the apoptosis process. In one of our publications in a British journal, we show a relevant statistic and the good correlation with breakup time and epithelium mapping. And we confirm also the tendency of the epithelium seeding in a more advanced dry eye. In the model mice, inducing after 7 days of the dry eye, we observe also an hyperplasia after 7 days. And the most likely hypothesis is the increase of pro-inflammatory cytokine is correlated by the cellular proliferation and can induce the hyperplasia of the epithelium. This hyperplasia occurred at the same location of the first rupture of the breakup time. And look here in the Nibud exam, the first rupture occurred at the same area of this hyperplasia. And look here, we observe in epithelium mapping the good stability of the information and this hyperplasia. We check with the en-face OCT, with the slab, the good thickness of the epithelium and confirm this hyperplasia correlated in this case of mammalian gland dysfunction. And look here, the correlation in case of incomplete blinking, we observe a very short breakup time correlated with the hyperplasia of the epithelium in the first stage of the dry eye with the advanced stage of mammalian dysfunction. And after the treatment, we observe normalization of epithelium shape with an increase of the breakup time. And now, with the Solix platform, you can have also the mammalian gland imaging and also the measure of the tear meniscus. And this is a case of different mammalian gland dysfunction with the atrophy of the mammalian gland. You can also use the color mode to analyze the inflammation of the blepharitis. And you can make a good correlation between epithelium mapping and mammalian gland imaging. And look in this case of a young boy of 11 years old. We observe MGD grade 1 associated with hyperplasia in the inferior part of epithelium thickness and associated with the normal thickness of the stroma. You can also identify the mammalian stagnant due to the incomplete blinking with the en-face OCT. You can use also en-face OCT to distinguish the lipid component in this instability during the dry eye. And look here, some cases, some different cases about the instability of this lipid component. So it takes sense that OCT may play an important role on multimodal dry eye screening with epithelium mapping, the measure of the tear meniscus and mammalian gland imaging, and also with the en-face OCT. And look, in this case, we observe an important instability of the lipid component. This instability is more pronounced on the left side, and we observe also a more pronounced seeding of the epithelium on the left side. That's why we can talk about the multimodality approach also for the anterior segment. And look here, this is a biomicroscopy picture with the presence of keratitis, en face OCT, and epithelium mapping. With epithelium mapping, you can follow the dry eye patient after the treatment. And look here, during the treatment, we observe the improvement of the epithelium mapping according to the subjective improvement. Before and after IPL, look the improvement of the epithelium mapping. Another case, before and after IPL, in very advanced memory gland dysfunction. And look here, you observe telangiectasia. This is before IPL, this is after IPL. You observe a reduction of this telangiectasia. Another case of more advanced stage of the dry eye. And look here with the incomplete blinking, scleral show, chalazion. This is before and after the treatment. And look here, we observe also a reduction of the force of conjunctival chalasis after the treatment. And you can also analyze this dynamic approach with OCT B-scan, with a vertical scan. You can see very well this conjunctival chalasis. OCT en face can bring codification of this flow. And look here, a case of patient with history of LASIK and PKR. We observe here a scleral show. We know after the LASIK and PKR, you can observe an hyperplasia of epithelium. And look here, before the treatment and after the treatment, you observe normalization of the epithelium shape. And it still remains a question, what is the role and the involvement of the ocular software disorder in case of refractive regression after refractive surgery? It still remains this question. And probably, in the future, we can analyze the eye drop persistence with epithelium mapping and en-face OCT. And look here, when you make an eye drop installation, we increase the epithelium thickening, and you measure the time to go back to the normal. And look here, this is the B-scan appearance, and probably we can use the OCT in the future probably in the pharmacologic study. You can have a very good information for the refractive to analyze the flap diameter before the new refractive surgery. You can measure the flap and the residual stromal bed very easily, even several years after. And you can use en-face OCT to analyze the cutting shape of the LASIK. And look here, you can see very well the cutting shape of the LASIK. With en-face OCT, you can move through the cornea to analyze the complication of the LASIK. And look here, this is a microfold within the flap inducing diffraction called the Baguini effect. And this is the drawing performed by the patient. The case of smile, look at the right eye, there is a very regular cutting shape. This is an incision and the cutting intrastromal cutting shape. And look here, there is a problem of docking, and still remain a piece of lenticle with a reflectivity in the interface. And look, the epithelium mapping. The epithelium mapping change also with the scare, with the stroma. Epithelium mapping can change due to the curvature changes also. Another case of epithelium ingrowth in the SMILE procedure. And look here, you can see the epithelium ingrowth with the on-face OCT. You can make a correlation with the epithelium mapping and look at the area of epithelium ingrowth. You observe epithelium seeding in this area. Another case of complication of LASIK after the new surgery. Look here, this is the first cutting. The second cutting, this is a microphone within the flap. The epithelium ingrowth, and this is the entry of the epithelial ingrowth and the B-scan corresponding. In PRK, you can see very well the aids thanks to the high resolution of the Solix, and you can make the merger to identify the location of this opacity. And you can you can make also the screening and the assessment of the refractive regression. Look, in this case, the patient treated for -8 diopters. You observe a very slight epithelium hyperplasia, but it's pretty normal. But we observe a small opacity inducing in this myopia. And also, epimapping can be useful for the keratoconus screening. Dan Russian was the first to describe this aspect with the seeding of the epithelium above the cone, associated with hyperplasia donuts. And look here, so this shape with the seeding above the cone associated with the donuts hyperplasia, and you have always to compare epithelial mapping with a stromal mapping to confirm this aspect. And look here, these changes was more pronounced on the left side, and you can confirm with the corneal topography. And this is a new display of pachymetry with total pachymetry, stromal pachymetry, and epithelium pachymetry together to make a very good comparison each other. And another cases of keratoconus in epithelium mapping, the right eye you have seeding of epithelium associated with hyperplasia, but on the left eye you observe first keratoconus, but you have a complete hyperplasia. It's epithelium reaction due to the dry eye. That's why you have to compare always epithelium mapping with stromal mapping. And look here, the stromal mapping on the left side, you observe the decentric aspect of the stromal mapping and the seeding of the stroma, confirming the presence of this first keratoconus. And you have always to compare if you have an hyperplasia just due to the dry eye, this is a normal stroma, or if you have epithelium changes and stromal changes confirming the presence or not of keratoconus. And for refractive surgery now, it's completely mandatory to compare corneal topography with epithelium mapping. In this case, the patient with a history of grass allergy, you have a beautiful meibomian gland dysfunction, more pronounced on the right eye, and you observe an hyperplasia in the inferior part on both eyes, inducing curvature changes, producing asymmetry in corneal topography. That's why now you will have a corneal topography on the Solix platform to have a better comparison between the corneal topography and epithelium mapping. We showed a good correlation with other topographer of the market, with a good quantification. And look here, you can make a comparison with epithelium mapping. In this case of keratoconus, you observe the seeding of epithelium above the cone. But it's always also useful to detect some curvature changes due to ocular surface, and this is the case of hyperplasia. And look, the same area, you have curvature changes inducing asymmetric of the corneal topography. In other cases, with hyperplasia, and look, in this case, the stromal is completely normal. And look, here the projection of the hyperplasia directly on the corneal topography. That's why it's mandatory to compare corneal topography with epithelium mapping and the stromal mapping. And look, we know hyperplasia can occur also in the curvature changes, and look, in this case of intracorneal ring in en-face OCT. And you observe also hyperplasia above intracorneal ring. With the en-face OCT, you can check the position of intracorneal ring in the whole surface of the ring. You can also check the contact lens fitting and the clearance of the scleral lens. And look here, there is a contact between the lens and the keratoconus. And you can use also en-face OCT and epithelium mapping to manage some corneal disease like adenovirus keratoconjunctivitis. We know it's a long resorption for this conjunctivitis, and you observe here, after the cyclosporine treatment, the improvement of the ocular surface and the reduction of the nummular aspect of the lesion until the complete disappearance of the nummular aspect and the complete resorption, complete normalization of epithelium shape. And this is the follow-up with the upcoming software and the trend analysis of the epithelium thickness, and you observe the improvement of the thickness of epithelium. You can analyze the surface of Cogan dystrophy, and this is a microfold of the basal membrane, and sometimes you have some changes, always associated with dry eyes in this eye condition. And look here with the en-face OCT. We can move through the cornea, and you can see this microfold of the basal membrane with very large view as compared to the confocal microscopy. Another case with the geographic aspect of the Cogan dystrophy. In case of cornea guttata, in B-scan, 2 dimension, you observe a very small hyperreflective punctuation. In en-face OCT, you observe dark spot due to the dysmetic guttata as compared to the specular microscopy. And now we can have a multimodal approach for the ESCRS screening with the en-face OCT, and you can measure the lesion with the B-scan. Here, another case of cornea verticillata, you have an aspect of the epithelium changes in this lesion. In B-scan, you observe a pseudo double aspect of the bovine membrane very pathognomonic about this corneal lesion. And look here, the high resolution of the cornea with the Solix. And you can also control the interface of the graph, the penetrating keratoplasty. And for society, you can see the scale of the penetrating keratoplasty. The video doesn't work. So it takes sense that Solix is a multi-modality approach with en-face OCT, OCT on geography, B-scan, corneal topography, neighboring gland imaging for retinal, glaucoma, cornea, dry eye screening, and refractive surgery. And thank you for your attention.